endlessly striving for better technology, OSTEM Implant is maintaining its unbeatable #1 place in the domestic implant market and making its way to becoming the top global dental company. Enhancing the quality of medical treatment, endlessly striving for better technology with leading technology. OSTEM Implant is maintaining its unbeatable #1 place in the domestic implant market. OSTEM Implant making its way to becoming the top global dental company. Sophisticating the treatment technology, enhancing the quality of medical treatment, endlessly striving for better technology to help anyone operate successful treatments. OSTEM is persistently seeking innovative advancements in implant technology. We have acquired FDA and CE approval subject to strict global standards. OSTEM is recognized for its technology and quality in both domestic and global markets. OSTEM has maintained its global #1 place in implant sales since 2017 as a distinctive brand most frequently used by clinicians around the world. OSTEM's innovation goes beyond implants, extending to all products and services for dental diagnosis. Products include Korea's top-selling dental unit chair, dental equipment such as CT with high-quality images, the most similar bone graft material to human bones, and dental resources including impression materials and orthodontics materials. Dental pharmacy services comprise comprehensive oral care and treatment solutions. Korea's top-selling dental software, such as the electronic chart, dental office management software, and examples of the wide-ranging products provided by OSTEM. Furthermore, OSTEM provides a dental office interior design solution that takes patient convenience into consideration. The solution ultimately contributes to create the ideal clinic environment. OSTEM, the digital dentistry leader, offers innovative digital technologies and products including computer-guided surgery, milling machines, 3D printers, and digital orthodontic lineups. OSTEM's corporate dental portal, Dental, has been spotlighted as a one-stop platform that provides services and information including education, news, recruitment, and software for clinicians. Advanced technology and premium quality are the drivers of OSTEM's development as a global dental leader. Securing a high-level dental laboratory, Central Lab, OSTEM now operates 15 dental R&D centers and invests 11% of corporate revenue in R&D. Top dental R&D researchers are striving to develop technologies and products that will lead the global dental industry. As a result, OSTEM has successfully established top-level implant technology and the largest implant product lineup around the world. OSTEM, the digital dentistry leader, established an R&D team for digitalizing dental treatment and proved its capability by setting up full digital dentistry product lines of equipment, materials, and total management software that can manage all clinical steps from diagnosis to treatment. While maintaining top-level quality, OSTEM has established global production bases in Korea, the US, and China, and is cooperating to achieve a better quality assurance system. OSTEM established strict quality management system, which includes high-tech production automation system, total inspection system, and quality tracking system for each process. Performs strict quality control inspections for each production process and product to meet the highest standards. OSTEM also contributes to society. OSTEM's clinical education programs are designed to assist with providing better treatment for both clinicians and patients, and extensively contribute to clinical development for clinicians all around the world. Moreover, OSTEM is continuously expanding its social contribution by sponsoring community service activities and dental academic organizations. OSTEM is also donating scholarships to dental schools and graduate schools for clinical dentistry. OSTEM currently has 13 business sites in Korea as we continue to expand our network globally. The headquarters and central research lab, which is located in Magok, Seoul, is maximizing synergy by unifying R&D capabilities in all fields of dental services. OSTEM is leading the global dentistry industry by expanding its global network to US, China, and Europe, running branches worldwide and exporting products to more than 80 countries. OSTEM is securing the world #1 implant sales company status by experiencing remarkable growth every year. OSTEM Implant's vision does not stop here. OSTEM Implant will strive to develop better technologies to lead the global dental industry that will contribute to healthier life in the era of 100-year human lifespan. OSTEM Implant will advance to become the global #1 implant company by 2026 and global #1 dental company by 2036. A company that is growing endlessly to become the global #1 in the dental industry. OSTEM Implant.
Hello, good afternoon, good evening, everyone. Thank you for joining us today. I am Dr. Rashmi Mirchandani here from Education Team OSTEM Middle East. We would like to welcome you all for the webinar series. At OSTEM Middle East, we are dedicated to delivering top-tier education to empower our dentists with the finest knowledge and expertise. As a part of our commitment, we have our webinar events for serving our Middle East customers in order to provide comprehensive solutions designed to help build an industry environment suited to globally digital dentistry. OSTEM Implant will continue its R&D and innovation with passion and relentless determination to take new challenges in the pursuit of new technologies. Once again, without taking too much time, I would like to thank each one of you all for joining and spending time with us for this webinar. I would like to hand it over to my team, Dr. Stephen, to take it forward.
Okay, hello everyone. Good morning, good afternoon, good evening, everyone. Welcome to OSTEM Middle East live webinar. I am Dr. Stephen Ahmed from OSTEM Middle East. I will be your host today in our session. In today's installment of our online webinar series, we are diving deep into the world of dental implant technology. Over the next hour, we will explore the latest advancement and techniques that are reshaping the field of implant dentistry. So our topic today is harmonizing perio-implant approach for superior aesthetic outcomes.
Good afternoon, Dr. Stephen.
Okay, can you mute?
I'm
Yes,
Ahmed.
sorry.
I'm Ahmed from A&H team. I'm only saying good afternoon for you and for everyone.
Thank you. Thank you very much. Thank you, Ramiz. Good to hear your voice. Thank you. Okay, so our topic today is harmonizing perio-implant approaches for superior aesthetic outcomes. And before we begin, allow me to introduce our esteemed speaker for today, Dr. Ahmed Ashraf from Alexandria, Egypt. As you can see, he is BDS, Master of Science, Assistant Lecturer of Periodontology, Alexandria University, Egypt, Clinical Supervisor in the Advanced Periodontal Practice Postgraduate Program in Alexandria University, Egypt, Clinical Supervisor in the Comprehensive Basic and Advanced Implant Program, Alexandria University, Egypt, and he is the OSTEM KOL. Before we kick things off, a few quick notes. Please ensure that your microphone is muted throughout the presentation to minimize the background noise. And if you encounter any technical difficulties, don't hesitate to write in the chat section. Without further comments, let's give a warm virtual welcome to Dr. Ashraf. It's over to you, Dr. Ashraf.
Good afternoon, everyone.
Good afternoon.
Dr. Steven, can you see my screen?
No, we need to share. Let's try to share again. Okay, now we see. Yeah.
Just a second. How is it?
Okay, nice.
Just confirm. I need to remove this. Okay, you hear me? You hear me good?
Yeah, all is good.
The mic is working good?
Yes.
Okay. Good afternoon, everyone. I'm really happy and honored to be with everyone with you today. This is Dr. Ahmed Ashraf. I am a periodontist, born and raised in the beautiful city of Alexandria, the north coast of Egypt. I'll be talking today about harmonizing perio-implant surgical approaches for superior aesthetic results, mainly in the aesthetic zone. And of course, I'm going to go through the function, through the soft tissue around implants in posterior area also, but mainly today I'll be focusing on the aesthetic zone. I've been working as a teacher in Alexandria University, teaching students for 9 years so far, concerning periodontal practice for the pre-graduate students and post-graduate students. Recently, I've been involved in lecturing in Egypt and outside of Egypt. It's really an honor to be a part of the big family of the Ostem company. That was the last meeting and the first meeting in the Middle East and Africa. And last February, there were a plethora of distinguished speakers. We lectured hand in hand. We shared stage together. The vibe was great. Everyone was helpful, and I wish this is the beginning of something big in the Middle East for the Ostem company. And I'm saying this today because the power of a teamwork always excel the results of your practice when you are into the implantology business. You cannot do everything, every job, the soft tissue and the good aesthetics with the smile aesthetics all on your own. You have to work in a team. This is Dr. Muhammad Al-Ashri. Also, he's an Ostem key opinion leader for the Middle East and Africa. We've worked together so far for 4 years as a perio-prosto multidisciplinary approach team. And of course, working together in a team with another specialty, you're a very good teacher and a very good student involved teaching each other specialties. Also, you cannot deny the efforts of those people. These are the prosthodontist team that I work with in the university. Each and every one of these guys taught me something, and we're forever learning together. Nothing you learn on your own is gonna be as good as when you learn in a team. Success is a team sport. This is the take-home message from my introduction, and let's go to our lecture today: harmonizing perio-implant surgical approaches for superior aesthetics. The digital technology nowadays has just immensely evolved in taking every other specialty of dentistry inside, co-working together, facial aesthetics with implantology, with periodontics, with prosthodontics. Everything is integrated together in a bigger picture to serve everyone. And first of all, of course, to serve our patients. So the predictability have improved with guided surgery, with interdisciplinary planning between multiple specialties to get what we plan. Of course, what we plan is what we need to get. And when you work predictable, when you work in a team, and when we work digital as much as you can, you get good results. But of course, when you when you're getting a beautiful restoration from replacing a missing tooth, you have so many factors. You have the implant depth, you have the soft tissue thickness, you have the positioning of the implant, mesodistal orientation, buccal orientation, the type of connection of the abutment, the color of the abutment. All these factors contribute to the final result. So getting from soft tissue, thin to thick soft tissue on implants, being hidden and bombarded by all these terms in the beginning of your practice, you have to have a scheme, like a roadmap to follow to master all these details with the positioning, with the zenith, with conditioning the tissues, with temporaries, with the loading protocols, and so on. So I'm going to start with the Smile Aesthetic Index. This is one of the indices that describe and assess the beauty of a smile. Simply speaking, what is wrong with this patient's smile? When patients come to us in our clinics, they're seeking treatment. Sometimes he's annoyed with something that he doesn't know. He tells you, I want to change the color of the teeth, and the problem is the size of the teeth. Sometimes you want to change the color of the gingiva, and the problem is the level of the gingiva. So this proposal just summarize the problems that are related to the smile into those 10 factors: color of the gingiva, gingival recession, gingival excess, scars, and black triangles. These are the 5 issues that a periodontist work on to get a good smile. Hand in hand with the prosthodontist, the color of the teeth, deformity of the teeth, alignment, midline, and smile line. Both together, hand in hand, get the very good result with superior aesthetics in the aesthetic zone. So, thinking multidisciplinary to cover everything, we have to train our eyes to think macro. We have to think on a bigger scale, on a smile scale, sometimes on a full mouth rehabilitation scale. Then we have to act micro, each on his own specialty. In different cases I'll be discussing today, about 10, 12 cases of this multidisciplinary technique or multidisciplinary approach on fixing problems. When to do temporization, when to do the final restoration, when to place the implant. It's about the timing and about the execution. So it all starts with diagnosis, and these are the specialties that are important to be there on a diagnosis team: prosthodontist, a periodontist, an orthodontist, and a maxillofacial surgeon. Although surgery is not intersecting so much in my scope of practice, but this is to have a bigger scope on treating every single problem. You have to have those 4 sit together, see the records, see the patient, and then put a common treatment plan that everyone is going to handle on his own phase. So we have patients coming to us. This is a small eye training exercise. The patient coming to change the 3 front teeth, 2 centrals and 1 lateral. He just had broken teeth under this bridge, and he needs to replace this bridge. Actually, it doesn't tell you about so much things. It doesn't tell you that the teeth are short. It doesn't tell you that the color of the gingiva is annoying. It doesn't tell you that he feels that the lateral is longer than the central. But when you do the smile analysis, you see these problems and you fix these problems, and you have this result with a happier patient. Always seek the best result aesthetically for a patient, explain with pictures and explain with previous patient data of other patients, and use them to excel the result from point A to point B. Same here, the patient's coming to replace a broken central. So if you want to remove the central and place an implant without doing anything in the adjacent teeth, 100%, you won't hit the perfect outcome with replacing a single central on its own. But when you go and do crown lengthening, elongate the adjacent teeth, and this is a temporary crown, by the way, I'm going to show you the final crown at the end of the lecture, you take the patient's expectation to another level that he does not know. Also replacing a single tooth restoration, a whole smile analysis, and a whole shifting from fixing a single tooth to a macro scale of thinking. Also missing lateral, flat ridge, no papillae. The adjacent teeth are short and needs lengthening. So we do everything at one time. We do the crown lengthening and we place the implant, and we're just waiting for the healing of this patient that's been recently operated on. Also, even with implants with crowns on them, see this, the left canine is longer than the right canine. Soft tissue is very thin, poor color. It's reddish or inflamed. The patient's complaining of a problem with the tissue around this canine. And this is after treatment. And we even lengthened the crowns of the centrals to match the smile curve with the lower lips. Again, single central. Coming the patient with recession wants to replace this tooth. You have to do your analysis, only putting an implant inside and loading it. After 4 months, you're going to get a very big crown without resemblance of the collateral central. With adequate soft tissue management, good temporization, and good loading protocol, you get the perfect profile that matches the other side. Even with very big cases like these, we do not lose hope on teeth. Periodontists, we always try saving teeth. So from this point to this point, and by the way, this patient didn't place a single implant in the maxilla. It was only in the mandible, 0-4, and in the maxilla was all soft tissue, pontic site augmentation, and crown lengthening. So getting your eye to spot out the problem. Either this problem is an excessive gingival display, tilted tooth, wide space that need to be orthodontically closed, or anything else, makes you a better clinician in fixing the patient problem. Sometimes patients do not know what do they need. They just come for a single tooth. He wants to fix this, and you need to educate the patient better on how things are done. And trained eye beats trained hands. I always say this because everyone, especially the young dentists, they all need to know how to cut, how to do surgery, how to do a crown preparation, how to do endodontic treatment in a very good technique. But no one trains his eyes. So training your eyes is going to make you a better dentist, is going to make your vision of the case more artistic, and is going to get the patient a better outcome and give you a better feedback from this patient. So you don't see what you don't know. You have to know these items, what to look at and what time. This is where digital technology has evolved, and where are we now? After doing the Smile Aesthetic Index on a 2-dimensional scale, you can carry this scale on a 3-dimensional scale, on a bigger scale, putting a smile design for a patient, having the CT of the patient, the face scans, and the intraoral scans superimposed on each other, and you have this virtual patient file with you in your clinic. You can do all these planning and all the raising of the vertical dimension, all the placing of soft tissue and increasing the volume, decreasing the volume sometimes, lengthening the teeth when you have virtual patient. All these ideas are related to the macro thinking. This is how you think. This is not how you work. After finishing all these beautiful planning steps, we go to the act micro. We go to everyone on his specialty has to know the rules of the tissue, the rules of the occlusion, the rules of the facial musculature to restore what was missing. We have to know these. So we go into deeper level into the planning. After the tooth positioning, we place the implant on a good distance from the final restoration. We plan how much bone do we need around this implant and how much soft tissue we need around this implant. You cannot get a patient, place an implant, and while putting the crown, start thinking, how am I going to make this crown look natural? You have to plan this from the start. After putting a plan, after doing the surgical guide, before placing the implant, you have to virtually place the implant and virtually plan the final restoration before doing the surgery, not before doing the crown. So this can encompass anything. It can encompass virtual crown lengthening, virtual gingivectomy, virtual pontic side development, whatever you want to do in your clinic. do first on the software. Do it without involving the patient in expectations and too much pressure on you. Do not do it on spot for the first time. Just do it in your office, on laptop, put the teeth wherever you want, and know what you will say to the patient, and explain to the patient why, for example, this case, why do we need soft tissue volume or bone volume on the labial side? That's why, because when we put an implant in a prosthetically driven position, the buccal thin tissue or the buccal bone is going to be inadequate. So eventually you're going to need this addition of a soft tissue or bone. And this is a very easy way to explain to your patient. When you have all these records, you start doing, you start explaining to your patient and leveling up your persuasion skills. Because if you cannot persuade your patient, or if you cannot explain to your patient, the patient won't let you operate on him. And the patient, you will not have a good skill and you will not have a good learning curve. Without knowing the problem, seeing the problem, and illustrating the problem to your patient, you will not work on your patient. So what's the point behind all the learning when you can't do it with your own hands? So what we learned in the past 3 decades, standing on the shoulder of giants, as we always say, a paradigm shift has just entered the field of regenerative medicine, guided surgery, guided tissue regeneration, soft tissue augmentation on implants. Those textbooks and all the papers out there are available to a lot of people now. This is so different from maybe 15 to 20 years ago. This was not present. Long-term studies were not there. It was all built upon small clinical trials, non-randomized clinical trials. We didn't have a consensus or a meta-analysis for certain problems. So things were just going around: bone thickness, crestal bone, and primary stability. Things were working like this 20 years ago, 30 years ago. But now we have other factors. We have tissue body type, keratinized tissue width, and the importance of augmentation of the keratinized tissue, peri-implant mucosal thickness, and implant supracrestal complex. With these four, we've got 7 to 12 years of success reported in literature with implants placed in deficient ridges, but having good soft tissue profiles. And these implants last longer in patients' mouth. And patients' feedback on implants with good soft tissue around them are so much different from a patient that's having a deficient mucosa, a movable frenum next to the restoration, pulling all the time, food impaction underneath pontics and underneath implant crowns. So things are different now. They're not just like before. We have a network, a big network of literature going on and paper connected to each other related to the soft tissue importance and soft tissue complications and time points of when to do surgery and when to postpone it. Okay, all these problems like facial recession, like facial tissue color, like thinning of the peri-implant mucosa and susceptibility to peri-implantitis happen eventually due to the cause of tooth extraction. After extracting the tooth, of course, according to the bundled bone theory, the whole thing collapses inside. The bone collapses inside and the soft tissue collapses inside. So you have deficiency on the buccal bone and on the soft tissue. And literature reports on immediate implants, on average of 10% of your cases, you're going to get mid-facial recession. And by personal experience, this is way higher percentage in thin bite type cases and in high aesthetic demand cases. When your patient is having a high smile line, you don't want this to happen after placing an implant and finding recession happened. 2 of every 10 patients or every 6 patients you do is going to have a recession in an immediate implant. And the delayed implant, 60% of patients are reported to have 1 millimeter recession after the first year. So you don't want to put an implant in an upper central, and it's 1 millimeter longer than the other one after only 1 year, and it's supposed to last in this patient's mouth without problems for maybe 10, 15 years without any notice. You don't want this to happen. This will eventually happen without you getting any hand in this due to the concept of bundle bone resorption after tooth extraction. So choosing the time point to interfere is a very important thing to fix those kinds of problems. Clinical soft tissue dimensions, according to this paper, has just summarized up the checklist that you should see while you're planning for implant placement in the aesthetic zone. The first thing is the keratinized tissue width. Second thing, soft tissue volume. Third thing, biologic width around implant, papilla height, and biotype. Those 5 prerequisites, you need a keratinized tissue width that's from 2 to 3 millimeters, at least by the literature. The second thing, soft tissue volume, you need 40% of the buccal tissue to be soft tissue, fixed, keratinized, and as much as possible with a highly fibrous content. The biologic width, you need a good depth of the implant, 4 or 5 millimeters from the zenith, to be able to create a restoration that's not pushing on the biologic width and on the implant supracrystal fibers, and the papilla height to look natural, of course, and matching to the neighboring tooth. And the biotype is what the patient comes to your clinic with. You never know the behavior of thin biotypes, totally different from thick biotypes. You need more preparation to do this. You can shift the technique of the surgery from only doing 1-step, 2-step surgeries to doing 3, sometimes 4-step surgery in thin biotype cases. So the 5 points just serve one whole purpose. And this purpose is having a good emergence profile around teeth. So when you're asked how to do a good emergence profile, the first thing you have to think about is those 5 points, the 5 dimensions of soft tissue around the dental implant. And of course, while planning your surgical guide from the start, or even if you're doing freehand surgery, you have to do a wax up, either virtual or in lab. And then you go to the patient and do the same plan, place the implant in the correct position with consideration to these 5. And this is the outcome that we need. We need a tooth that looks exactly like the neighboring tooth in terms of soft tissue and in terms of ceramics. So it's not always a good looking prosthetic that is going to add more beauty to your restoration. Always think about the pink aesthetics as much as we think about the white aesthetics in the teeth. So the shift in the concept of implant survival has not been like the matters and the factors that we looked at before. It's not about the bone thickness and the primary stability anymore. It's about the successful implant emergence profile, successful smile analysis, and tooth harmony with the adjacent teeth and with the smile curves of the lips and of the patient's face. So what we learned actually in the past 3 decades, that survival is not success. Success is a whole new thing where function and aesthetics are integrated together to get a beautiful restoration, to optimize the implant profile through very good bone, very good soft tissue, healthy mucosa, a good implant position, and a restoration that complements everything together. Those are the 4 factors I'm going to talk about today in our cases. And optimizing each and every one on its own gets you a whole big result. You cannot get a good result without good mucosa or without good restoration, only based on the implant position and the bone. So bone giving the tone and the tissue is the issue. We all, of course, know these 2 coats, especially the periodontists. I'm sure there are people with us today that are more experienced than myself and have placed a bigger number of implants. We are here today to share concepts and to change mindsets that we've been used to for a long period of time. So always 40% tissue, 60% bone. When you're having around an implant 5 millimeter labial to the implant from the platform to the soft tissue. You need these 5, you need 2 to be soft tissue and 3 to be bone. Always memorize these numbers. You need soft tissue with all the cells, with all the immunity, and with the thickness, of course, of the connective tissue to cover this bone and protect this bone and seal the way down to this bone so the bone can give the tone and the mechanics. If this bone is exposed to the environment, you will not have healthy defense from the bone. The bone is a weak immune system connective tissue type. Bone is not like soft tissue, not like epithelium, not protective, and it's not like connective tissue with all the immune cells and all the macrophages and the neutrophils. So the soft tissue is the first sealing barrier that hinders any external stimuli like bacteria and toxins from entering to the bone. Perio-implant health in the last 2017 consensus have been described in those terms, in consideration to the thickness, keratinization around the implant, the at least 2 millimeter, as we just mentioned, and 4 to 5 millimeter labial to the implant platform. From the implant platform to the labial soft tissue should be 4 to 5 millimeter to get a healthy crown with long-term follow-ups that without problems as peri-implant mucositis or peri-implantitis regressive bone loss. And surprisingly, the soft tissue does not only contribute to having a healthy, to having a good-looking tooth, but also to getting stable marginal bone. Marginal bone loss is something that happens all the time due to the lack of the presence of soft tissue. When you're having good, thick tissue, rarely when you see a tooth with significant bone loss, of course, the initial bone loss of remodeling, 0.5 millimeter in the first year, 1 millimeter in the first year, this is accepted. But more than this, be sure that this patient is having a soft tissue problem. When you see an X-ray with bone resorption, always go to the soft tissue. See the soft tissue around the implant. How is it? So in terms of the height of the tissue and the width of the tissue, it has to be this number that we just mentioned, 4 or 5 millimeter in all directions. Do the surgical guide plan according to this parameters to get a distance on the buccal and a distance on the vertical. And the second thing after the tissue is the restoration. Placing a very good restoration will protect the perio work. Nothing ruins the work of a good surgeon or a good periodontist like poor prosthetic design. When you're having a good prosthesis that's polished, that's all smooth and without any rough parts, any plaque retentive areas, sealing the contacts with the adjacent teeth, looking exactly like the adjacent tooth, all these factors contribute to the healthy soft tissue. This research by Ramon Meida describes the curve of the subgingival curve, the critical and the subcritical contour of the prosthesis. And simply, it describes the distance needed by the connective tissue and the junctional epithelium and the sulcar epithelium on the prosthetic. If you have less than this distance, connective tissue attachment will not happen, will not find a space to take place just adjacent to the implant. So you'll definitely have violation of the biologic width, 1 point of the 5 points of soft tissue dimension. And of course, the sulcar epithelium lies in the aesthetic area or the E zone, where you need to bulk up the restoration somehow and increase the volume to create an aesthetic appearance of the gingiva, a natural appearance of the gingiva. So the EBC zones, you're all familiar, of course, with different nomenclature of the idea of the biologic contour, either EBC zones, critical or subcritical contour. But at the end of the day, we all understand that having bulky restorations are not a technique that we do nowadays. We always have an undercontoured subgingival restoration with a good implant depth, so you can do this flaring, gradual flaring of the emergence profile, and you can support the tissue. This highly polished subgingival part can support the soft tissue through the contour of the material. And we cannot, of course, overlook the type of material that we're using an abutment or a crown. made of printed resin is not like made of titanium and not like zirconia. Of course, having a higher polished surface, a more biologically compatible material like titanium and zirconia with very high level of polishing will have very good sealing around the implant and will enhance the fibroblast attachment on the crown. On the other hand, using printed resins, mainly printed resins, you'll always have problem with this attachment because it has high bacterial adhesion and high roughness. It's not polished, the printed resin. Always use the milled resin better than the printed resin. And with the zirconia, very highly polished surface, all the subgingival areas that are going to be embedded in the soft tissue have to be very highly polished, like you see. This is the custom abutment and with a temporary milled crown. Also, the pieces of the crown that are getting contact with the soft tissue needs to be very highly polished, not glazed. Glaze is not a good medium for fibroblast attachment. So getting abutments that are highly polished, either titanium or zirconia, and getting Emax crowns that are highly polished in adjacent to the soft tissue will preserve the profile after long years of service with the crown. Arrays and tests and research have been done on fibroblast toxicity, how much resins are toxic to fibroblast. And like I told you, milled resins are always more biocompatible than printed resins. 3D printers are very handy, and I know many people have 3D printers in their labs or in their clinics. It's easy to use, and you get the contour that you need. But unfortunately, the degree of conversion, it's a resin. It's like the composite material. When you're having a degree of conversion that is not to the most of the material, you have residual monomer inside the material, and this irritates the tissue. So after having the 5 points of soft tissue and a good restoration together with thick bone, you'll have a stable supracrustal complex, a stable tissue on the implant, good tissue, good bone, good implant position, and good biological restoration. These are 1, 2, 3, 4 prerequisites for a good restoration that follows the perio-prosto protocol guidelines. But there is something missing. There is something missing. If you do all these, you have not to overlook the occlusion. The fifth element of the perio-prosto protocol in restoring a teeth aesthetically and functionally is very good occlusal scheme. And this is a very, very important job of the prosthodontist. And I've learned a lot from working with many super talented prosthodontics in relation to occlusion, bite, wear, and doing a lot of bite changes and a lot of raising, a lot of interferences. I didn't understand those factors when I was working a periodontist on my own. So discovering premature contacts have just differed so much from only doing it with articulating papers to doing it digitally with many occlusal sensors like T-scans, like Oculosense, and even some softwares provided by intraoral scanner companies can do some detection of high points and so on. But at the end of the day, when you're having a premature contact or an interference on an implant crown, you're risking the bone and the tissue that you've built or that you're preserved. If the patient is coming with good tissue and you place a beautiful implant position, a beautiful restoration, but you do not consider the occlusion with time. So these are the 5 perio-prosto considerations that you need to know. The first 5, you remember the first 5? Were the 5 dimensions of the soft tissue, and these are the second 5, the perio-prosto consideration. So we only have one remaining 5, and these are the 3 5s that we have today in the lecture, and this is our take-home message. You have to consider a good tissue thickness, good bone volume, 40-60, as just explained, good implant position with an adequate depth and medial-distal orientation to get a good restoration, a biological restoration curves, EBC zones, very highly polished, avoid printed resin, always go with milled, always go with zirconia, touching your soft tissue, and finally, occlusion. So the last 5 items, and these are the bulk of the lecture, where the cases are the interesting part. The 5 time points of surgical interference to fix the problem. Mainly, I'm talking today about soft tissue problems, and we'll have, of course, more and more opportunities to explain more about bone grafting, guided tissue, and guided bone regeneration, and several techniques of autogenous bone harvesting. Very interesting. So we can interfere and do the surgery before we place the implant. Of course, this is not so handy. Patients need more motivation and explanation to do this, to do only a soft tissue surgery without putting an implant inside, without doing a crown. He doesn't know why are you doing this. Of course, you will provide all the planning records that I just shown you in the beginning of the presentation. Then you will take this patient on an educational journey. Why are you doing this? Why are you doing soft tissue surgery first? The second thing, during the implant placement, and this is my personal favorite, all the time, whatever you can do while placing the implant, do this. It's a bit risky and a bit demanding in terms of time, technique, teamwork. You need many things to be ready, and I don't do it all the time, of course. It has its drawbacks in terms of cutting blood supply, doing more manipulation in the tissue on the implant. So sometimes we go one thing at a time, or you can do it after implant placement. While you're waiting, in the waiting period of 3-4 months, you can do this interference in soft tissue, or with connecting the abutment. Of not doing this so much now, maybe sometimes with small healing abutments. And last thing, after crown delivery, and this is not recommended, of course, it's not recommended to leave the problem till you deliver the crown and you start thinking about fixing this problem. So before implant placement, this patient came to us wanting to restore this remaining root of the upper central, but unfortunately, we didn't have apical bone to fix or to get primary stability of the implant. Yet, we will go for alveolar ridge preservation. We're gonna do grafting of the socket, soft tissue grafting, and bone grafting. As I mentioned before, the bundled bone theory states that when you get the tooth out, the socket is gonna collapse inside, and you won't get good volume for placing an implant after 4 months. So what you do now, he was traveling for 6 months. We grafted the socket with allograft and placed the soft tissue from papilla to papilla, as we always recommend. And it's not my words, these are the words from the literature. The technique by Dr. Zucchelli just stated that we need to graft from papilla to papilla to have support for the soft tissue underneath, not to collapse, not only the mid buccal portion. So this is an ovate pontic we prepared before the surgery, going inside the socket 2-3 millimeters. This is a recommendation also from the literature to support the tissue. Then the patient came after 6 months with beautiful tissue, and this case just transformed from a high risk immediate implant, high demand case to a straightforward case. Now you can place your implant and you can do a temporary crown, or you can put again this mirror line bridge, this ovate pontic, you can put it inside again after placing the implant, and then restore this after 3 months. This is how it looks at the baseline, and 6 months, nearly nothing has changed. What was going to happen if I didn't put inside the soft tissue? If we don't consider the shrinkage of the tissue like the shrinkage of the bone, we always consider shrinkage of the alveolar bone, so we place grafts inside the socket. When we place a soft tissue, you also preserve the contour. This is something that is very hard to restore once you lost. The second thing is during the implant placement. And as I told you before, this is a very common practice that we all do. After placing the implant, just tunnel a partial thickness tunnel. Always better to do partial thickness incisions in immediate implant placement to, as much as possible, not cut the whole blood supply from the buccal plate of bone. It's very thin and it's very liable to bone resorption. So actually in literature, sometimes it is reported that this method cuts the blood supply from the buccal plate of bone and causes more bone loss and more remodeling with time. But if you can postpone it, it's better to postpone it. If you want to do it in the same time and the bitype is not so thin, it's okay to do it immediately at the same time. And of course, tooth extraction. I'm sorry, the videos were shifted. Tooth extraction has to be as much as possible without trauma to the buccal bone. Buccal bone is really important to keep it safe while you're doing the extraction. This is an extraction post I've used recently. Of course, luxation is done with sometimes piezoelectric tips or with peritomes. Then you get out the tooth, you place inside the implant, then bone graft in the gap, soft tissue graft, and a custom made healing abutment. As much as possible, let it be polished. This is composite resin, light cured composite. There is a degree of conversion that is not transferred into complete polymer. There are free monomer inside, but as much as you can, do it polished, and you'll have beautiful healing. This is after maybe 3 weeks of healing. This is how it looked in the before with recession. Before was even receded, then the adjacent central. Then this is how it looks after 4 weeks. Leave this patient for maybe 10 more weeks, and we're going to start the loading with our final crown. Another case that we place the soft tissue in the surgery, preparing the surgical guide to optimize the implant position. Always try to be away from the buccal plate 3 millimeter. 2 millimeter is very tight on placing the bone graft or on maybe some errors while you're placing the implant. During the drilling, keep the position 3 millimeter from the buccal bone as much as possible, and during the planning of the surgical guide. Also, the depth of the implant has to be 4 or 5 millimeter, and the distance from the buccal tissue 4 or 5 millimeter. Sometimes you take an intraoperative scan for preparing a temporary restoration in the second visit. So we test the temporary abutment, and we place the scan body inside, and we get a very nice scan of the tissue and of the implant position, but yet we don't have an emergence profile to take scan for. Then we place the soft tissue inside, suture it with positioning suture at both sides from papilla to papilla, grafting the jumping gap with allograft, then sealing everything with the socket seal abutment or the custom made abutment. It's either called socket seal abutment or a custom made abutment. Then this is another scan that we do maybe after 4 weeks of healing. I see the contour is beautiful on the buccal side, and the resemblance between the gingival margins of both teeth is very good. After 4 months, we go back again and scan the tissue profile for the final restoration. We can add on the soft tissue, we can add on the custom made abutment, on the socket seal abutment, more composite resin to shape the profile. And gingiva or soft tissue or mucosa is like a water balloon. Whenever you press in a certain direction, it will follow this pressure. That's why we don't do over contoured restorations, in order not to force the tissue back. But in the conditioning phase, you can do many healing abutments that shape the profile gradually from a small one, because you don't want to do much pressure in the first 2 months. You start doing this on the 3rd and the 4th month and doing the final restoration. It has to be away from the papilla as much as possible, with no pressure. This is the scan. This is a clinical picture. This is the final shape. And of course, we take shade for the zirconium abutment underneath. And this is the final restoration, looking beautiful. Another case that's more complicated than first 2 ones, and it's having something that it's very interesting when you're having in your clinic, and you feel lucky when you have it in your clinic. This patient is coming to us with short clinical crowns that need to be lengthened with gummy smile. She's having gummy smile. And when we explain the procedure, the planning according to the smile aesthetic index, and the planning according to the 5 dimensions of the soft tissue around this implant that we're going to place in the central, that you need crown lengthening and immediate implant placement and soft tissue augmentation simultaneously. You need to do everything simultaneously. She agreed, and we started our treatment. This is how it looks after tooth extraction. We opened a full thickness flap on the adjacent teeth to be able to do the osteoplasty and the osteectomy. Then, after doing the gingivectomy, we have the new gingival zenith, the future gingival zenith of the final outcome of this patient. Then we start working accordingly in placing the implant 5 mm deeper to this future zenith. 3 to 4 is not so comfortable. 4 to 5 is more comfortable and is more predictable when you're doing a prosthesis at the end. Why those cases are very lucky to have? Because actually the soft tissue shrinkage after surgery is going to be compensated by the lengthening or the elongation of the adjacent teeth. So you won't get much recession that affects the final outcome yet. Yet after placing the implant and debridement of the socket and debridement of the excess root canal filling that has been out there due to several surgeries and maybe an apical surgery also, we placed a collagen membrane to fix this apical fenestration and preserving the periosteum on the buccal plate. Always do not overwhelm the buccal plate by flap reflection, suturing, much manipulation. You're going to have big resorption. Place a soft tissue graft from papilla to papilla. Then now we took an intraoperative scan like the previous case and placed only just the healing abutment submerged with open healing technique. We didn't advance a flap. Advancing flaps in the aesthetic zone causes shifts in the mucogingival junction. And you don't want to do this. You don't want to get the mucogingival junction to shift occlusally. So we do the open healing. Then this is the temporary crown that came from the lab after 3 weeks. And interestingly, not surprisingly, of course, we predicted this. Interestingly, the excess tissue is going to follow the contour of the crown. Thanks to the grafting, the soft tissue healed beautifully and followed the contour of the temporary crown coronally. And as recorded in the literature, that you need an 0.5 mm of excess or of an overcorrection to compensate for the soft tissue loss that is going to happen in the first 3 months. First 3 months after placing an immediate implant, you have, even if you graft it, even if we place a soft tissue graft, you're going to have soft tissue recession that's about 0.5 mm in the first 3 months. This is the normal remodeling process of any soft tissue, even in recession around teeth. So this small part just gives space for a second temporary crown to come in here and just improve the level by doing a contour on the temporary crown to push the gingival zenith for this half of a millimeter. Getting overcorrection is better than undercorrection. And undercorrection, you will not be able to do a second surgery just to pull it for 0.5 or 1 millimeter. It's better to do it in advance in the first surgery, then push it back by the contour of the crown. This is the contour of the crown, the first one and the second one, with a thicker contour. If this is composite resin, you can add more composite in this part. And this is how it looks on a morph video. The movement of the tissue is beautiful. It's like water balloon. You press it from one side and it just goes with you to the other one. Look how the soft tissue follows the contour of the final crown. This half millimeter is a room for the prosthodontist to work in. Getting him an equigingival levels between two centrals is not something good. It's very intimidating to do restoration when you don't have soft tissue to push. This is the final restoration, and this is the natural tooth untouched. Only crown lengthening on the adjacents. Sometimes we have to do this with more buccal soft tissue loss. When we're having this amount of soft tissue recession, this is probably a type 2 extraction socket with minimal buccal bone dehiscence that we need to place the implant. And this, in this case, we didn't do much than only a soft tissue graft. This is a 3.5 millimeter Ostem implant. Then tunneling of the buccal, soft tissue, of course, partial thickness tunnel, get a tuberosity graft. And the quality of the graft here is very important when you're getting high hopes for soft tissue thickness and soft tissue advancement. Tuberosity grafts are always thicker and more fibrous, and they have less shrinkage than palatal graft or deep connective tissue grafts. You either use tuberosity graft or superficial connective tissue grafts that just below the epithelium. This is how it looks immediately. This was the patient's own crown, the Emax crown, just converted it into a temporary crown on a temporary abutment and screw it inside, screw retained restoration. And this is the healing after 4 weeks. What's happening here is the soft tissue is following the contour of the crown. Always do an under-contoured, highly polished crown to be very biocompatible and non-irritant to the soft tissue, and use a thick graft. See the volume, the fill on the buccal of the implant central. Then this is the final result. Of course, we kept the diastema as the patient didn't want to touch the rest of the teeth. And if I were this patient, I wouldn't also loved to do preparations for all teeth just to close the diastema. It was okay with her. And of course, you tell the patient, you explain the smile aesthetics, but you have to respect the patient's autonomy. Not all the time you have to do what you have to do. This concept of placing soft tissue with implants is not all, it's not only for immediate implants. You can do it with delayed implants. You have soft tissue defects, place the implant inside with the soft tissue simultaneously and use a socket seal abutment or a custom-made abutment that just forces the tissue outwards to shape the emergence profile. You can do it for pontic side developments. Right? We were placing 2 implants for the central and for the canine, and we have a lateral pontic site in between. Place the soft tissue one stage with the implant and see how the bulking up of this area that we need to get a very good result. This patient is undergoing a full mouth rehabilitation, and the outcome is very important to match the other side. Also, during implant placement, we can place tabletop grafts. Tabletop grafts are partly on the occlusal table of the bone and partly on the buccal surface. So when you're getting a saddle type graft, you get very good height and you get very good width. And pushing it back with healing abutment can give you a very good buccal volume that resembles the other central. And now it's a straightforward case for the prosthodontist. Very good depth of the implant. It's easy to restore. Just take a scan, send it to the lab. You won't have a hard time restoring this. If we didn't do this soft tissue surgery with the implant surgery, you're gonna need to do it right now when you're delivering the crown, or you're gonna do a crown with pink porcelain or a saddle type crown covering the soft tissue to mimic the other one. But now you have very good tissue volume and very good depth. We can place a custom-made abutment or a screw-retained zirconium crown or a screw-retained ceramic crown that opens up this profile more and more like a water balloon, like I just said, to get an aesthetic restoration. Sometimes things are more and more hard. In this case, a little girl, 20 years old, just got an accident and broke her front teeth, especially the central. It got broken with the buccal plate of bone. Very hard case to treat, and we chose to extract the tooth first and leave the soft tissue to heal to help in the surgery. So if you decided to do surgery in this condition with this tooth in place, this is not a wise decision to do. Extract the tooth, leave it to heal to as much as you can. Not so much than 6 months, but maybe 2-3 months is okay. 1 month is a minimal, and 6 months is a maximum. Then we do just a provisional restoration. Luckily, this patient had a low smile line with not so much high smile line, and we're starting counting our problems. Many problems that I see here, you have to train your eye to capture the problem, and you have to start solving it afterwards. The first thing is the soft tissue defect, and of course the bone defect. The second thing is the high frenal attachment. The frenum is just located on the buccal, mesiobuccal aspect of the other central, and with surgery and with tissue manipulation, this is going to get on the ridge. So the papilla, the frenum is a high risk factor in this case. Narrow zone of keratinized tissue, we don't have but 1-2 millimeter from the creeping, but from the mesial and distal sides after tooth extraction. So narrow zone of keratinized tissue makes augmentation and makes aesthetic result poor and harder technique to do. This is after flap elevation. We saw this big defect, use pericardial membrane. We don't need rigid membranes and these confined defects, and you either place mixture of allograft and xenograft to get best of both worlds. I'm sure we're gonna have more opportunities to talk about bone graft materials, but I always use either 50-50 allo xenograft or autogenous, of course, 50-50 or 100% allograft. It's the easier option if it's available in your country. It's a very good option and a fast healing option. You can, after 3-4 months, you can open and start your treatment after doing allograft. This is how it looks after 6 months. Very good buccal fill, not the optimum, but of course it's better than before. Still having high frenal attachment, so I did frenectomy in this stage. As the first surgery was not a big augmentation surgery, so it's not a high risk to start it without doing the frenectomy. And I started to do the frenectomy here. Still, we're having a soft tissue defect and a bone defect in the central. Yet, very good bone to place the implant. But like I said before, survival is not success. Placing a good implant that's getting a very good primary stability and an integrated implant with a good crown does not satisfy patients, especially this age group, especially that she's the female. So you need more aesthetic demand. You have a more aesthetic demand in this case. So this is very good bleeding bone after exposure. Like I told you, allograft or a mixture of allograft and xenograft to get vital bone, implant placement in a prosthetically driven position. Then now we have buccal bone that's enough. We have these more than 2 millimeter of buccal bone. Yet we're doing the mini sausage. Mini sausage is a concept introduced by Isvan Urban. Urban is the godfather of one of the godfathers. I know it has been a widely discussed topic in the literature, either by textbooks or by papers. Urban has described the concept of the mini sausage by adding more bone graft on the buccal, especially after grafting for the first time. When you graft first surgery, you expect this bone volume to reach the final shape after maybe 1.5 years or 2 years. Nobody's going to wait 1.5 years for the bone graft to reach the final shape, then place the implant. So on the way, you place the implant in the 4th month, yet you know quite well that the volume will not be as stable as you just placed this bone 4 months ago. So you need to compensate for this shrinkage by the mini sausage, and you need to fill more buccal soft tissue, more buccal contour to carry the soft tissue to a more buccal position, carry the keratinized tissue to a more buccal position. Then going in again, then suturing back again with the same problem. Now we come to the uncovering of this surgery, maybe 4 months later. Now we consider the collateral aesthetics or the collateral teeth. We have a short lateral incisor, and we need to do gingivectomy or clown lengthening in this lateral incisor to match the other one. So this is an internal bevel gingivectomy, a crestal incision. Now we continue with a partial thickness incision to separate the mucosa from the periosteum. As much as possible, do not remove the periosteum out of grafted bone. This is double grafted bone, the first sausage and the second mini sausage. So as much as possible, keep working in a partial thickness manner. Then in the apical part, we do the deep split to have good release of the tissue. Only open on the implant and remove the cover screw, putting in the healing abutment, doing the osteoplasty on the adjacent teeth, removing bone on the adjacent teeth to have a good length of the lateral that matches the other one. This is the smile. These are the smile aesthetics that we talked about. Tuberosity graft, always going tuberosity graft to get good volume, because I need big volume for this case. It's essential with the high aesthetic demand. And the suturing is pretty forgivable in this situation, that it's going to be inside the flap. So you either suture to the flap. I find this technique an easy one, reproducible and teachable. You can teach it to your students. With a mattress suture, we hold it into the mesial papilla and to the distal papilla by 2 mattress sutures here and here. Then now the connective tissue is attached to the flap as one unit. We can connect the healing abutment. This is the third type, soft tissue grafting with the connection of the healing abutment. Then get everything back in place. See, the mucogingival junction now has shifted more apically to have better keratinized soft tissue on the buccal of the implant, then holding everything back again with interrupted sutures. Honestly, I would prefer to use a bigger healing abutment or a custom-made abutment, but unfortunately, it was not available at this moment in the surgery. But it's okay. You can do a smaller one, place the healing abutment, then come back after maybe 3 weeks, 4 weeks, and put a bigger one and push the tissue. It's like a water balloon. It's going to expand and reach the final level that we need. We test the mobility of the tissues. It is, of course, it's a bit mobile, but so far so good. These are the pictures, more details. Periosteum exposed, only exposed the cover screw. Then putting the connective graft inside. See the color of the connective tissue graft. This white color indicates it's a tuberosity graft. It's having high fibrous content and less blood vessels and less fatty tissue. And of course, it's better with the healing. It does not cause inflammatory reaction or much shrinkage. This is the positioning suture going into the flap, then to the graft, and back again to the graft, then to the flap, and suturing everything together. This is how it looks after the water balloon effect, putting a bigger one after 4 weeks, getting a very good contour on this central that matches the other one. This is the final restoration. And this is how it looked like. And this is the transformation journey from a high gingival level on the previous two to be extracted and what we've reached now. Honestly, also, I could think about a free gingival graft to augment or add more soft tissue on the central, on the left central, but yet we're waiting for the patient follow-up after 2 months to try to do the next step surgery for this central. This is how it looks now. A beautiful smile for a beautiful young lady. The stick by type mandate connects tissue graft with exposure of the implant. Do I have to do this all the time? Do I have to do soft tissue when I expose every implant in the aesthetic zone? Honestly, like I've mentioned before, that we need 40% tissue and 60% bone. So if we're having thick bitype cases, the tissue is very good, and you only need to add more bone inside, either on the first surgery or the second surgery. You can skip the soft tissue part. This is a very good biotype patient, did a bone shell technique or a Khoury technique to compensate for a buccal ridge, to a labial ridge deficiency, horizontal deficiency. Then this is how it looks after 6 months. Putting inside a small healing abutment that inflates the buccal tissue and increases the contour of the buccal tissue without grafting. This is auto grafting without doing any complex procedures. But do not put a big one in the beginning. Just put a small one, then start replacing this small one with a bigger one after 1 week. 1 week is good. You can do it after 1 week or after 2 weeks. It's okay. And on the process, when we put bigger healing abutments inside, we just create pressure on the sulcular epithelium around the abutment and improve and refreshen this attachment from the previous abutment. It's not good to place a bigger abutment than the final crown. It's always good to place a smaller healing abutment than the final crown, then put the final crown inside to shape the final shape of the tooth. This is how it looks with the temporary crown. And this is the temporary crown in place. Looks beautiful with the soft tissue resemblance between the two centrals. Very symmetric. Of course, we kept the diastema. This patient is a very good friend of mine, and he didn't want to touch the other teeth. And honestly, it's going to be a hard case with this chalky white spots and this discoloration on all his teeth. So we kept the diastema. He's very satisfied with the outcome. And we did not do any fancy or any hard techniques in the second stage surgery. Only exposure with a small abutment, then putting in a bigger one. short clinical crowns with missing central and bridge defect. Now we have both two last cases, one with short teeth and one with a soft tissue, a bone defect. Yet we have very good thickness of the tissue and we have very good height of the keratinized tissue. See the central, the mucogingival junction on the missing central is at the same position like the other one, which is 5-6 millimeter of keratinized tissue. Now we open the flap and assess the dehiscence, place the implant. Then this is also pericardium with 50% xenograft, 50% allograft, getting everything back again in place. And as you just noticed, I didn't do anything about the short teeth in this surgery, as augmentation surgery needs much demand from the adjacent soft tissue. So if you're planning to do a secondary crown lengthening, don't do it in the same visit with augmentation. Just do the augmentation, come back again, and assess what you need. Collateral aesthetics is all what you need when you have short teeth. Doing aesthetic crown lengthening, this is an internal bevel gingivectomy on the left central, and see the keratinized tissue in the right central. Very good, yet still collapsed. But do I need to graft it? Let's see what happened. This is a temporary crown screwed inside by a screw hole that was on the buccal due to the implant angulation. How it looks after 2 weeks. Then we leave it more and more, 4 to 6 weeks. Then do minor adjustments, minor soft tissue laser adjustments. Then this is how it looks like after 4 more weeks of healing. 8 weeks of healing. Soft tissue is beautiful. Even the stippling is still there, even after tooth extraction. Then we prepared the other central. It was endodontically treated and needed to do a crown on the central. This is a beautiful soft tissue healing after the temporary crown was inserted without any soft tissue grafting. Perfect contour on the labial. Only select the good cases to do this. Not all cases you can skip to graft the tissue. Sometimes you need more tissue. Sometimes you have good biotype that can compensate for the tissue. The healing, the custom abutment, of course, all the time away from the papillae, not to exert any pressure, not to lose this beautiful triangles between teeth, away at all aspects from the labial view and from the occlusal view. It should not touch the adjacent teeth. And of course, this should be planned prior to implant placement. Not put the implant so much mesial, so much distal, you're going to lose the privilege of getting good papillae in the aesthetic zone. This is how it looks like in the trial of the final crown. Then polishing of the abutment, ensuring everything is smooth, nothing is glazed that's going to go under the tissue. Everything smooth to just improve tissue adherence on the abutment. This is the trial of the final crown, how it looks like. Soft tissue looks beautiful 2 weeks later. Always take time. Take time. Do not set your patient on high expectations. I'm going to put the crown inside in 2 weeks, 3 weeks. No, you cannot do this. Always explain that we have a second surgery. We have conditioning phase. We have temporization phase. Explain this from day one, from the first visit that you see your patient. Explain all these details. Then this is the final crown after cementation, after I think 2 weeks of cementation. The frenum has been located at an apical level. Very important. Take care of the frenum. It can ruin everything. You do a beautiful job, and then the frenum comes and destroys everything. These are all the steps for the case, and this is the final outcome. Another one with a very good biotype that we didn't need to do a soft tissue grafting in, a patient coming to us to restore a lateral incisor, yet with also short clinical crowns need aesthetic crown lengthening. Yet there was no space between the two roots of the central and the canine to place the implant. And we have tilted teeth. Now we need an orthodontist. To fix this without an orthodontist, you're going to risk the roots of the teeth. You're going to risk preparing all the teeth, doing veneers or doing crowns, and exposing the patient to very high expenses, and yet not the perfect, at the end of the day, treatment plan. So now we need adjustment of this implant space by moving the teeth around by the orthodontist. We do a veneering graft as the buccal bone was very thin in the apical part with the collagen membrane, and you can use here xenograft as this is not touching the implant. And this bone, we won't drill again in this bone. This bone is just for veneering, just for layering. We don't have to put autogenous or allograft in this situation. A xenograft will do the job. We'll give the very good volume, covering it with any non-rigid membrane. Then this is the advancement that we see on the right. See the advancement tissue level from the right part to the left papilla between the central and the lateral. We have to match these two levels together for the final papilla between the central and the lateral to be as good as the other side. If we don't advance the tissue very much on the left side after doing the guided bone regeneration, you will have a deficient papilla and you will have a black triangle between the central and the lateral in the final restoration. Then we went for the aligner, orthodontic aligner. And this is how the teeth have moved away from the implant. And this is the final custom-made zirconium abutment with the final Emax crown. You see the papilla are still soft and bulky. Now, after insertion of the final abutment with the final crown, it's going to follow the curves of this crown. See the lateral on the left one with good papilla compared to the other one. This was because of the advancement that was done in the GBR, the guided bone regeneration. This is not due to the soft tissue grafting. We didn't do any soft tissue grafting in here. Only bone graft.
Okay, hello everybody. I think Dr. Ahmed, he has a technical issue. Maybe we can unmute Dr. Ahmed now. Okay. It's muted.
Do you hear me?
Yes, we hear now. Okay.
It's okay? Working?
Yeah, now that was one.
Okay, back again. So we don't have to do the soft tissue
Share screen.
during.
We have to share screen again.
Okay, just a second. It's working?
تمام.
Right. So we don't have to do the soft tissue during the implant placement or during or before the implant placement. You can do it after the implant placement. In this case, after placing the implant and, of course, grafting the jumping gap and placement of the immediate temporary restoration that, as much as possible, resembles the gingival margin of the neighboring central. In this way, we have a predictable soft tissue loss in both the vertical and horizontal directions that we should know before working and tell the patient you will have soft tissue recession after this surgery, and we're going to need another one to fix it. Why do we do this, or why do we go for doing two surgeries, not just one surgery? Actually, as I told you before, in the literature, cutting out the blood supply from the buccal plate of bone is very thin. After tooth extraction, there is no bundled bone inside the socket. So a very high percentage of bone loss will happen, and cutting out the blood supply from the buccal plate makes things worse. So what you need is a healthy buccal plate. Then you can go inside and increase the thickness with a soft tissue graft. So connective tissue graft has been used widely in the literature for this purpose, as we just said, as we just saw. This is the defect. This is the technique. Like I showed you before, putting the graft inside with positioning sutures, then preparing a temporary crown that is under contoured. And here we need more tissue advancement, as we had recession in the vertical direction. So we need this tissue to follow the contour of the new crown and move in a coronal direction. So we do the double cross technique, or the double cross sutures, or suspensory sutures on composite resin in the contact between central and the lateral, and on one side, and the two centrals on the other side. This will pull the gingival the tissue margin around the temporary crown in a more coronal direction. We either take a bite in only the flap, or we can take the flap with the graft in the suspensory sutures, according to the biotype, according to the experience of the clinician. It works both ways. Taking the graft, of course, is more biologic, not to exert much tension on the tissues, but yet it can expose the graft, and you should have a completely enclosed graft in this surgery. Do not expose your soft tissue graft. This is how it looks, a coronal advancement by the suspensory sutures. And after 4 weeks of healing, beautiful images profile following the temporary crown that has been relieved, of course, not bulky, not convex, only concave profiled subgingivally with good implant depth to take the gradual flare. Always good. Go 4 or 5 millimeter apical to the buccal zenith to be able to do this gradual flare in the crown. This is the 1 millimeter overcorrection that I just talked about before, to keep a safe margin from the soft tissue shrinkage, and for the prosthodontist to create a tissue profile with the pressure by the final crown. It went more down after 8 to 12 weeks. Maybe we need an extra 0.5 millimeter to match the other central. This is before and this is after. With the buccal soft tissue, as we said before, 40-60. 60% bone, 40% soft tissue, 2 to 3 millimeter of buccal soft tissue is beautiful. Then we can record the emergence profile. We should record the emergence profile in the final restoration. I didn't mention this part in the planning phase, but we don't only create it, but we also record it. After creating a beautiful profile in the clinic, or you can do it with a temporary restoration, or with a lab fabricated temporary restoration. We have to record this for the final restoration to match this part. So you either do it with composite resin on temporary abutments or temporary impression copings, or you can do it with a scanner. If you have access to intraoral scanners, you can take a scan to the emergence profile and see the soft tissue for the final crown to be screwed inside without so much pressure and without changing the zenith that we've reached. This is a custom-made zirconium abutment. Of course, the finish line is subgingival. Then the final glass ceramic Emax crown to match the beautiful color of the adjacent teeth with the soft tissue, with the stippling. When you see stippling on the buccal tissue, you know this is an immediate implant, or a delayed immediate implant, or an early placement implant. Stippling does not simply isn't present in any ridge part, only in the attached gingiva. And he's smiling back again with confidence. Just a second. Now we can do this also with the abutment connection. One of the most common procedures that we do after the guided bone regeneration, or after grafting bone, is grafting the soft tissue that is covering this bone. Because actually we increased the ridge width by grafting bone, so we need more soft tissue to advance to cover all this grafted area. So it's ruined. The keratinized tissue is shifted on the buccal surface, or on the occlusal surface, sorry. So you need to create more keratinized tissue on the buccal by pre-gingival graft. This is one last part of our lecture today, is dealing with present crowns with gingival problems, gingival biotype problems, or color problems, or even sometimes oozing, bleeding on probing, causing pain for the patient. You see the left canine is longer than the right one, and the color of the tissue is pretty dark. It's pink or dark red due to peri-implant mucositis, inflammation on the buccal part, with also thin buccal plate of bone. You can say it's a thin buccal plate of bone. The problem here is not only fixing the tissues, but also fixing the restoration. We talked before about the prerequisites. Number 1, tissue. Number 2, bone. Number 3, restoration. Then occlusion that we need to get the final outcome. So this abutment with this angulation is not a good candidate for soft tissue grafting. So we remove the crown and we just reduce the abutment as much as possible. We won't need this. We're gonna throw it away and get another one. Then put a connective tissue inside. Then suturing back again, as we saw in the previous videos, to cover the under-contoured temporary crown on the reduced abutment. Then we start fabricating a new custom-made abutment. But as you see here, we didn't use metal in the aesthetic zone in any of the other cases. This time, a metal abutment was used. A metal custom-made abutment was milled of titanium and polished, of course, due to the position of the screw channel. The screw channel was too close to the buccal surface of the abutment. So you either go buccal with the abutment with more tilting and have an unaesthetic restoration and undermine the buccal soft tissue, or you can just under contour the abutment, use a thinner material. This thickness in zirconia is going to be very weak and it's going to break. With titanium, you can reduce it down to 0.3, 0.2 millimeter, and it's not as much as risky as zirconia. So with this case, I chose to use the metal abutment. Sometimes you use an opaquer over the metal abutment to cover the color of the metal abutment. And then this is a temporary crown inserted inside to test the phonetics, test the occlusion, interference, patient feedback, and so on. Then we go and put the final crown. This is the case before, and this is the video showing the bulking up of tissue from papilla to papilla. Very important, always graft from papilla to papilla. This is how it looked before, and this is the creeping of the tissue, getting better thickness, better color, and even better tooth color match with the adjacent teeth. And let me get this video back again, and I want you to look at the canine tip. The canine tip also is getting shorter, and getting a shorter canine tip is under the frame of respecting the guidance in order not to get a very long disocclusion time in lateral and protrusive movements, and minimize the pressure on this tooth as much as possible to fulfill a good stable supracrustal tissue or supracrustal complex, or just to preserve what you've created. You did a beautiful job on the soft tissue and a beautiful job on the restoration. You have to respect the occlusion to maintain all these jobs that have been done. This is how it looks like before and after. Now the canine is nearly the same length as the other one on the adjacent side, the right one, and the tissue looks pretty pale and thick like the adjacent teeth gingiva. So a take-home message for today's lecture: the 5, the 5, and the 5. What are the 3 5s? The first 5 is the 5 dimensions of soft tissue: keratinized tissue, soft tissue volume, biologic width, papilla height, and biotype. The second 5 were the perioprosto considerations: tissue, bone, implant position, biological restoration, and occlusion. And the last 5 are the 5 time points of surgical interference that we can go inside and do the surgery with very predictable outcomes, and choosing a better time frame to do your surgery is like choosing the right patient for the right treatment. It's not optional, and it's not a thing that you can just overlook and don't respect. Thank you so much for your attention, for your time. And this is my link. If you need anything, you need to ask about any further data, and I'm open to questions, and I'm open also to feedback. Guys who are happy, just tell me why are you happy, and guys who didn't understand, just tell me anything you need me to explain again.
Okay, thank you very much, Dr. Ahmed, for your interesting lecture. I'm sure we learned a lot today. And thank you for your time and participating in this webinar.
Thank you, Dr. Steven. Can you see me?
Yes, yes. So
Can,
now we will check if anyone has any question. They can write it down in the chat section. So, so far we have 2 questions.
Yeah, of course.
Does crown lengthening affect the width of attached gingiva?
Yes, of course. This is a very good question. Actually, the width of attached gingiva is a predeterminant on which technique we're going to use in the crown lengthening. When we have very good attached gingiva, more than we need after cutting, if for example, you want to cut 3 millimeter of the tissue and you have 9 millimeter of attached gingiva, this is very good. You can cut and do the crown lengthening without any worries of doing any problems. Yet, if you're having only 3 millimeter and you need to cut 2 millimeter of the tissue, then we don't do this. We shift to another treatment. Another treatment option is the apically displaced flap. We just open a flap without cutting and without gingivectomy and suture it at an apical level to get the whole thickness of the keratinized tissue from a coronal position to an apical position without cutting through the gingiva. But in this case, we cannot do an implant because apically repositioning, you're going to put the flap in an apical direction on the teeth and a coronal direction to cover the implant. So you can do this if you're placing a healing abutment on the implant. Maybe you're getting a very good primary stability, or you can do this as a 2-step surgery. You do the implant first, then go back again in the exposure, connect the healing abutment, and do the surgical crown lengthening on the adjacent teeth.
Okay,
it's
thank
clear
you
now?
very much. Yes, it's very clear. Thank you very much. So we have also another question. What is the best way to preserve the papilla in immediate implant placement?
I showed several techniques in the immediate implant placement, but the best way, first of all, atraumatic extraction while removing the tooth, then placing an immediate temporary restoration and filling the jumping gap without condensation, without much condensation. Only place the bone graft inside and place an immediate temporary restoration. This will get you very good papillae. Yet, if you can do soft tissue graft, you can do this during the implant placement, it's going to be better. If it's going to be too much for the patient or too much for the surgical setting or for the team, you can do only the implant on a day with the immediate temporary crown and then go back again and do the soft tissue after 2 months. Okay.
Yeah, thank you very much. So our next question is from Dr. Ashraf from Ethiopia. He wants to know about the mini sausage technique and more explanations.
The sausage technique is grafting with any graft material, xenograft, allograft, autogenous bone, anything, and covering it up with a collagen or a pericardium membrane, or any type of membrane. It's the concept of guided bone regeneration, of grafting bone. So when you do this with a membrane, it's called sausage technique. When you do a small sausage for one tooth, it's called a mini sausage, but it's not a different technique. It's the same thing. When do we do this? We do this if we've done a first big sausage or a first mini sausage, and you are afraid that this bone will be lost after 1 year or 1.5 years, because bone continues to shrink in the first 2 years. The volume of the bone, the grafted bone, the grafted bone is not like the native bone. It has different behaviors. So to compensate for this shrinkage of bone, you add more bone the second time, just in case the first bone resorbed 20%, 10%, you will compensate with this. This is the concept of the mini sausage. We do this in all augmentation procedures, especially if we're drilling and placing implants in the second time. So, like the case of shown, we place the implant and do extra sausage, because drilling in the grafted bone, placing an implant with the torquing it inside, all this is stress on the bone that is grafted. So you need the mini sausage to be in the safe side and not be worried about the bone resorption.
Okay, thanks again for answering this question, Dr. Ahmed. Okay, yes. Thanks, Dr. Ashnafi, for your question. Okay, so if anyone has any question, you can write it down in the chat section.
Any other questions? I'm reading the questions now.
Mm.
Any more questions?
Okay, so I think for now there is no questions, but everyone already could see Dr. Ahmed's contact. He can contact him anytime, ask him questions anytime. Also, this lecture was broadcasted on YouTube, so you can come back to the YouTube and review this lecture and find the contact details of Dr. Ahmed. Okay, so we can end up our webinar here. But before we end, we would like to announce about our upcoming webinar. This will be in 26th of July with Assistant Professor Wasim Manhal from Lebanon. It will be the second part of his presentation about lateral bone augmentation with OS Builder. When, how, and why. So we are waiting for you all, and soon we will share the registration link, and we will keep you updated with the exact time. Okay, also we in the chat box, we shared our social media links, so you can also go to our social media channel and subscribe, so later you can get all the updates and the time of our upcoming webinars and events. Okay, so thank you, Dr. Ahmed, very much. And it was very
Thank you, Dr.
interesting
Steven. Thank you,
lecture.
everyone, for your presence
And-
today. And I hope that we have more opportunities on sharing knowledge, learning from each other, and have a happy holidays. Thank you.
Yes, happy holidays for everyone. Thank you, everyone, for attending our webinar, and we hope to see you soon the next month. So have a good day.